For 7 chapters, we followed one visit as it became raw material. It was born, it was coded, it was linked to the same person across sources, it was de-identified, it moved through an invisible supply chain, and we learned exactly what it can and cannot see. That was the whole point, to understand the material. This, finally, is the build, because knowing the material isn't the goal. Turning it into a service someone will pay for, that's the goal. So let's assemble one, live, from everything you now know. First, what are you even building? Almost every patient data product is one of a handful of archetypes. Real-world evidence for pharma. Does this drug work and is it safe out in the real world? Payer and provider analytics, cost, quality, and utilization. Risk adjustment, making sure a member's true burden of illness is captured and paid for. Clinical decision support, putting the right insight in front of a clinician at the moment of care. Patient-facing tools, and commercial targeting for life sciences. Each archetype has a different buyer, a different data shape, and a different bar for rigor. So pick your archetype first, because it quietly decides every choice after it. Now the foundation nobody puts in the pitch deck. Remember Chapter 3, every source speaks a different grammar. Before you can build anything durable, you have to make them all speak one. That is the job of a common data model. The dominant one is OMOP, from an open community called Odyssey. You map every source, claims, EHR, labs, into one shared set of tables and one standard vocabulary. And once your data is in OMOP, something powerful happens. An analysis you write once runs, unchanged on any other OMOP dataset in the world. Your work becomes portable, and your results become comparable. It is unglamorous plumbing. It is also the difference between a real platform and a pile of one-off scripts. Here is the subtle skill that quietly decides whether your product is right or wrong. Your data is standardized, so now you go to define your cohort, say, diabetic patients, and you discover there is no column that says diabetic. A diabetic patient is not a field. It is a computable phenotype, a definition you build from diagnosis codes, plus lab values like an A1C over 6.5, plus prescriptions, plus timing rules, plus real clinical judgment. Change that definition even slightly, and your cohort and every number you report changes with it. Two competent teams can define diabetic differently and reach different conclusions from the exact same data. So phenotyping isn't a pre-processing step, it is where your product's credibility is actually won or lost. Now watch everything you've learned become a single product spec. Take a concrete wedge. Help a health plan find members whose charts show a condition that was never properly coded, so their risk is captured accurately. Decision 1, the archetype, risk adjustment. Decision 2, the data, claims plus EHR. Decision 3, access, partner with the plan who already holds it. Decision 4, linkage, tokenize to connect each member's claims and charts. Decision 5, compliance, operate on the plan's own data under a signed agreement. Decision 6, model and cohort, land it in OMOP and phenotype the exact gap. Clinical evidence present, matching code absent. And the wedge economics, each accurately captured condition is real, recurring revenue for the plan, while your data and build costs are a fraction of it. 6 decisions, 1 spec, and every one of them came from a chapter of this course. So here's where you actually are now. You can look at any healthcare data opportunity and scope a real service. Pick a use case, a data source, an access strategy, a linkage plan, a compliance posture, and a first wedge, and know why each choice is what it is. We spent 8 chapters following one visit forward, from a moment of care all the way to a licensable product. And the quiet superpower is this: you can now run that whole path in reverse. Start from the service you want to exist, and you already know every decision standing between you and building it. That was the missing operating manual for the raw material of health tech. Now go build something true.